All right, we're back here in the Dr. Darian Parker podcast, where we always bring you reputable, credentialed, wonderful human beings to talk about different bodily systems. We're a real emphasis on science and diving deeper into that. And today, I'm so excited. We have Dr. Adeel Khan with us, who I had a great offline conversation with. I feel like we just really enjoyed chatting with each other, and so we were saying, "Man, this is already happening. We're here at the podcast now." So excited to bring this to you. Adeel, thanks for being on here.
Well, thank you so much for having me, Darian. And it's my pleasure to be joining you on the show here. So, to tell just the audience a little bit about myself, so I'm a hematologist oncologist. I'm an assistant professor of medicine and public health at the University of Texas Southwestern Medical Center in Dallas. I'm the director of myeloma epidemiology research there, as well as the clinical director of the monoclonal Gammopathy Precursor Clinic. And essentially, my focus is on hematology, specifically hematologic malignancies, blood cancers. And so it's my honor to be speaking about what my passion is here.
Yeah, it's wonderful. And so our focus today is really on blood and and I always say this, I know this probably sounds like a broken record to the audience, but I really want people to have an operational knowledge of the bodily systems and components we're talking about. Too many times we just skip ahead to more complex issues in whatever we're discussing related to any scientific thing, but most people don't know the basics. We got to get the
Hmm.
basics down first. So we're gonna go on to the basics about blood and then get more complex related to different blood cancers and things of that nature here. So Deal's gonna walk us through. I'm gonna have some questions obviously along the way, as I always do. But let's kick it off.
All right, sounds good. And blood, I think, is just such a fascinating topic. So I sort of say that the study of blood exceeds even that of hematology per se, because it really is such an ancient discipline that sort of our modern way of looking at it with clinical hematology is really actually one fraction of it, but it really has been our most revealing fraction of how we study the blood. Just give a little bit of an introduction of what we're talking about here. So blood is a connective tissue. There are four connective tissues in the body. We talk about nervous tissue, we talk about muscle, we talk about epithelial tissue, and connective tissue. And blood is one of those connective tissues. But I think it's best and most easily thought of as really a liquid organ. It's its own sort of liquid organ in very fundamental ways. And in terms of then components, I like to tell my students blood is cells and substances, cells and substances. So, it's about if you spin down a tube of blood in a centrifuge, about 45% roughly is cellular, and the remainder, the 55%, then is plasma. If you then take out some of the coagulation factors from that plasma portion, what you have left then is serum. And within the cellular components, you have white blood cells tied to immunity, red blood cells tied to hemoglobin and oxygenation. You have platelets tied to coagulation, and you have innumerable proteins, electrolytes, and other compounds all floating around, and really what ends up being the soup of this liquid organ. And as vital as we make blood sound, whether it's in our conventional speech, it still is worthwhile to ask, like, what's the purpose of the blood? Why did that evolve the way that it did? And fundamentally, it ended up being that way because it serves as the transport medium for the body. So anything that your body needs to get from point A to point B, whether it's a hormone from your pineal gland going down to the rest of your body, it uses the blood as the vehicle to do so. And so there are innumerable substances in the blood, and again, in some ways, it ends up being sort of a logistics, moving from point A to point B. So what consumes products from the blood? Well, quite literally everything in your body. Everything takes away something, and in some way it's tied to then what blood is doing. So the organs that are fundamentally connected to it is one, the vascular system. So whether we're talking about arteries or veins, they are all transporting the blood. The heart, as we know, is pumping the blood. Spleen is filtering the cellular components of the blood. The kidneys are filtering sort of the liquid and electrolyte components of the blood. The lungs are moving gases then in and out, and the GI tract is providing some of those materials for the blood. So it all very much ties to this fundamental issue of what the blood does and what it serves. Um, I think it's fair to say that the most important component of the blood is hemoglobin, and that's because it binds oxygen. And oxygen, I think, in conventional speech, we've made so fundamental to say that oxygen is fundamental. But really, it's worthwhile to ask, well, why actually do we need oxygen? Have we really paused to think about that? And the true answer to that gets, I think, a little bit technical, but basically, it's the final receiver in the electron transport chain of the Krebs cycle, also called the citric acid cycle. And so it's vital for us to make ATP, adenosine triphosphate, which is vital for energy. So oxygen is very much tied to our ability to make and manipulate energy. Now you could then also ask, why do we need energy? But it's hard to get more fundamental than that. So
Right.
oxygen very much tied to energy, and insofar as blood serves that purpose, blood then becomes very fundamental. One of my favorite factoids about blood is that we've always thought about blood, I think, as this red substance, right? That's what we think
Mhm.
about. We talk about things being blood red. But you know, across the animal kingdom, that is actually not all blood. That's not how all blood appears. That's very much kind of our mammalian bias. And for us, it's because of the hemoglobin. So it's the that specific molecule with its iron moiety that binds oxygen that gives it that red color. And even within our bodies, it's not always the same color. So arterial blood is sort of this bright, kind of pure red, if you will, versus venous blood can be a dark burgundy, almost even bluish purplish. But still, that's still with the spectrum of red, the way that we conventionally look at it. But if you take something very different, like a horseshoe crab, very kind of ancient animal, which, you know, evolved hundreds of millions of years before us, their blood is very much blue, like just straight up blue. You take as blue as you can think blue, it is that blue and then more. And in their case, it's because they use a different protein entirely, hemocyanin, which is actually a copper-based molecule that binds then oxygen. And it gives it this, again, bright blue color. And there's still then more out there. So certain types of earthworms, leeches have a chlorocrurin, which has a very green sort of color to it, and it's almost like a booger green. It is
Mm.
very green. And then some marine worms and brachiopods have these hemeranthins that are hemeranthin molecules that are make blood give a very purplish hue, kind of a bright violet. And this is all blood as we would define it in the conventional sense. And so this is the same substance, quote unquote, but how animals have evolved it has actually been different. And so what we speak of is not necessarily the same across the animal kingdom. Some basic facts that I'd like to offer. So, you know, if we take a given 70 kilogram, roughly 150-ish pound human, how much blood is it within someone? And it's roughly about 5 liters. And usually that's somewhere around 7 to 8% of our body weight. And we like to then talk about how much really gets pumped out. So that 5 liters is just constantly recirculating.
Right.
So cardiac output, which is the stroke volume of the heart times how much the heart then beats per minute. If you multiply that out, that cardiac output of the blood comes to about 7,200 liters a day. So it is just passing and coursing through us constantly, doing its job by providing substances and getting filtered and with all these materials exchanged in and out. And those numbers assume like a 70 kilogram male with a mean heart rate of 70 and are at around the 5 liters of blood within him, as I sort of said. And so every second, there's a tremendous amount of material passing through us. Now, the cells that then make up the blood are also being very rapidly produced. So the bone marrow is where all of the cellular substances in the blood are made. By and large, there's actually something called extramedullary hematopoiesis that can occur and things can happen in the spleen and liver, but by and large, it's really all the bone marrow that makes our blood cells. And roughly every second, there's about 2 million blood cells being made. That means in a day, there's about 200 billion going on. The whole body in general has cells on the order of trillions. It's hard to quantify something that large. And so blood, you get about 200 billion new cells per day. Now, that's kind of an equilibrium because so many cells are also just dying off and being cleared out. So your blood remains in this equilibrium of rapid transit, rapid growth, and then decay as well. I think the history of hematology is also just particularly fascinating because it truly is an ancient discipline. I mean, blood was
Yeah.
something that was very noticeable, you know, even before anyone took a scientific crack at it. But I think we often attribute a scientific look to the ancient Greeks. So people like Hippocrates, who spoke of like the four humors, yellow bile, black bile, phlegm, and blood. And so bloodletting ended up being this ancient medical therapy, one of the ways to restore the balance of the four humors. Again, this was their understanding of illness. And that really, you know, persisted in one form or another
Mhm.
in different pockets of civilization, really up through basically the 19th century. I mean, that really was something that people did for a long time. And of course, our modern understanding has exceeded that, fortunately. Um, but it's a gradual process, and discovery of the circulation of the blood is usually credited to William Harvey in 1628. Although there's some evidence that Muslim and Eastern scholars might have had an earlier understanding of the fact that blood exists in these vessels that continually moves around much earlier than that. And blood cells were discovered really as soon as the microscope was invented. So that's something that Anton von Leeuwenhoek did in around 1674, taking blood cells under what was a primitive microscope held to light to identify that this is not just a pure liquid per se, but there are these things swimming within them that are what we call cells now. And modern hematology then, from all of those steps in progress, gets attributed to three or four people, and it of course depends on who you ask. But the people I'd like to highlight as being sort of the fathers of modern hematology are one, Max Wintrobe, who was a doctor who was instrumental in characterizing particularly anemias and how we then count blood cells and characterize them. So things like mean corpuscular volume, mean corpuscular hemoglobin, different ways to actually mathematically and scientifically characterize blood cells is attributed to him. And he also produced the first textbook in hematology, what was in 1942, the clinical hematology textbook, which in some form still actually exists very much today, something that I learned from. So, and that ends up being sort of a landmark in the field. And then there's Donald Metcalf, who was instrumental in studying hematopoiesis. So the process that our body makes cells is hematopoiesis, and looked at cytokines, colony stimulating factors, different ways that blood cells then grow. And his work in that was, again, vital in our understanding of hematology, and he's credited often as a father. And then finally, I'd like to highlight William Demeshek, who did a lot of early work in blood cancers and was the founder of the American Society of Hematology, as well as the cancer journal, excuse me, the journal Blood, which ends up being the most preeminent journal in both benign hematology and malignant hematology across the world. And both the American Society of Hematology and the founding of this journal have been instrumental in our continued progress because it has been really kind of the top tier within the field. I like to break down hematology in really two broad flavors, and it can be divided in others as well, but two broad flavors. And one is there's benign or classical hematology, which is the study of things like coagulation, hemostasis, thrombosis, so fundamentally blood clots and things surrounding it, cytopenias and the cellular disorders, so whether it's platelet disorders or anemias, and then sort of the bone marrow failure syndrome. So things like aplastic anemia, which is sort of like this situation of all low cell counts for various reasons, or some of these congenital failures of the bone marrow to make blood cells appropriately. And then there's malignant hematology, which could also be called hematologic oncology or the blood cancers, and that's my particular focus, which broadly is well differentiated between leukemias, lymphomas, multiple myeloma, and then I'd also include stem cell transplant, also called bone marrow transplant, and cellular therapy is all in there.
Yeah. I bet you just, well, let me interrupt real quick. One, amazing stuff, incredible stuff. I want to back up just a little bit because I was like,
Yeah.
man, I have a lot of questions. I have a lot of questions here. One about blood volume. Now, as someone who teaches exercise physiology, I talk a lot about this in terms of the effect of exercise. And a lot of the students who are listening to this are going to be in healthcare, but also exercise scientists, professionals. Can you talk a little bit about the effect of exercise on blood volume, particularly?
One of the most interesting things that I think we have come to learn about blood volume is that it is actually dynamic. And if you talk about the components within the blood, so particularly like red blood cell capacity, that actually changes. So, a very famous case of this is if people living in higher altitude in areas, they have more of a stimulus because of the even small amounts of hypoxia from the reduced oxygen tension in the environment to then make more blood cells. So it basically gets detected by the kidney. The kidney then detects that change and spits out more erythropoietin, and then the bone marrow is stimulated to make more red blood cells. So famously, some of the long distance runners from Kenya have higher hemoglobin values. People living in Colorado have higher hemoglobin values. And of course, there's a lot of genetic aspects that go into that and the degree of elevation and the chronicity of that elevation. But that's something that then changes. And then another thing that's interesting is that, we talk about the blood volume because I think it's a simple metric, but as the vessels actually are dilating and constricting, the functional volume does change,
Mm.
and the degree of that change depends particularly on the arteriolar dilation, which can change from disease states to other physiologic states. And so it's not a fixed value. It is constantly something that then is shifting.
Yeah, no, it's amazing. I'm amazed at the adaptation that the body makes on all different systems. But with blood, it seems I remember learning this when I was in college, well over 20 years ago, and I'm like, wait a minute, you have 5 liters, but you can have more blood. I was like, more
Yeah.
blood? Like, wait, how is there a limit to the amount of blood volume that could be? Is there a top level, like a top off? Like, hey, you're having this stimulus adaptation through exercise. Let's say, so they're like, hey, we can't produce any more than this. Is that an issue at all?
Well, I mean, you could say, if you think about us as bags, yeah, you could think of that there's a
Yeah,
point where that bag just gets too filled.
right.
I don't know what that is. I'll admit I
Yeah,
don't know what that is. There are some disease states, and this actually ties to some of the blood
right.
cancers where there is an overproduction of blood products, of blood cells particularly, and even some non-cancer states where that does occur too. One of them is so the opposite of anemia is polycythemia. And in polycythemia, you have too many red blood cells, too much hemoglobin floating around. And that can be from a couple of different causes. There's what we call polycythemia vera or secondary polycythemias. And they're the hematocrit. So if you
Hmm.
spin down that tube of blood, what fraction of it ends up being the red blood cell mass? That can exceed from what is typically around 45%, up to 60% or even actually more. But that's a disease state, so that's not supposed to happen. And then in certain forms of leukemia, especially, and where actually that name comes from, we'll delve a little bit more into that. Um, your blood can be overrun by white blood cells, these
Mm.
sort of progenitor white blood cells. But those are again all disease states. They're not supposed to happen. So the dynamic fluctuation actually still within a pretty tight range, and that's around 7 to 8% of your body weight. And I've really not heard of it going above 10%
Mm.
in typical circumstances. So this is a pretty well regulated vital liquid organ.
Yeah, it seems like it because I start thinking, I'm like, hey, there's often a idea of diminishing returns. Like if
Hmm.
you're overtraining or doing too much, there becomes an idea of like, well, listen, there becomes irritability, loss of appetite, lack of sleep quality, all those things. And I don't, we were talking, I was like, wait a minute, is there an upper limit here where
Mm,
like what you're doing, whatever stimulus you're providing and causes this adaptation of increased blood volume. You're able to, increase stroke volume. Like, is it detrimental at some point to have
yeah.
that much blood volume that is
Yeah.
not caused by a disease state?
Right. I don't know that there truly is. You could always think of
Yeah.
someone who could theoretically overexercise, but the body does pretty well.
Mm.
It seems to be that there's always a new peak every Olympics. We're always talking about it. Um, in those pathologic states, one thing that does become sort of a limiting factor, if you will, is the viscosity of the blood. So as it
Yes.
becomes more cellular or more proteinaceous in certain other disease states, when that viscosity increases, and that's something that we can actually measure in the clinic, that actually becomes a problem. And people can have issues of it can gum up the kidneys, it can cause blood clots, it could even sort of affect then the brain, the CNS, cause things like confusion. But again, that's not a normal state. That's nothing that
Mm.
exercise will get someone to. Exercise, if anything, will help all of those
Yeah.
situations, not harm. Yeah.
No, that
And I
makes
think what's
sense.
also, such an important point as you're alluding to is the cardiovascular adaptation around just the blood itself is
Yes.
also just so fundamental to how we respond to it, and the ability of the vascular system to accommodate then the needs of the body, which is really what it's aiming for in its adaptations. It seems to be limitless.
Yeah, that's amazing. I mean, that's incredible. Actually, I find that amazing. So as we dive into like pathological states here, I'm Curious before we get into that,
Hmm.
is there any current, I don't know, I want to say this, mysteries about blood we don't know at this point? Or we're like, well, we're in the dark in this area about blood. Anything like that?
That's a great question. I'll say one thing that was such a question for a while that I think we have a better understanding about now. Was why of all places was the bone marrow why where blood cells are made?
Mm,
I think that's kind of weird. Like
it
why
is
why is
weird.
it yeah, it's right like this
Strange.
solid thing that's supposed to support us as kind of the scaffolding. It's just hollow enough that that's where the blood cells come from, and why is that the case? I remember I had that question a long time ago, and there's been, kind of decades long of small pieces of understanding that kind of came to it. And the best answer that I have is this, and I think this is just really interesting, that if you look at other species, blood cells are not, in the same way that blood is not all the same color, blood cells are not made by the same organs or analogs, if you're looking across different aspects of the kingdom Animalia. For instance, in like even mice, it tends to be made more by the spleen than bone marrow. And in other more primitive life forms, it's made more spontaneously within just the medium of blood that is floating around. There's just an ongoing form of hematopoiesis that occurs. But why in our case is it so tied to the bone marrow in mammals? And it seems to be that when during evolutionary times when fish came out of water, there was an immense amount of ultraviolet stress that became very much an issue. And because of how cellular the blood is, again, it's spitting out, billions of cells a day. The opportunity for even a small chance of error means that the risk for a mutation that's unfavorable or a cancer that then is obviously unfavorable becomes that much higher because, again, you're spitting out so many cells. It's one of the most active areas with cellular division in the body in general. And so, as a protective means from actually the ultraviolet stress of solar radiation, these progenitor cells moved and migrated into the bone marrow. And some of the evidence that we have for that is that if you look at fish, they do not have that bone marrow hematopoiesis element to them. They have a different structure and it's made more spontaneously within their sort of abdominal cavity. Versus if you take whales and dolphins, whose evolutionary journey was they were onto land as earlier mammals and then moved back in, their blood cells are moved almost 100% within the bone marrow. And yet the situation of what they would be experiencing within the water is really the same if you think about it. It's only because they took that trek through that they have then that reason for it, and that was preserved. And then if you look at us and other mammals that had more and more ultraviolet stress, it became more concentrated in the bone marrow in general. So that's the best explanation that we
Yeah.
have, and I'm sure as we learn more, we'll probably figure out
Yeah.
more along the lines.
Man, that's actually amazing. And it actually makes me think of too how blood functions in different environments, say such as humans underwater or in space, and the wild stuff that blood does and being again just any stimulus and changes environment. And we talked about high altitude and stuff, and we don't have to get into that, but it just the adaptation machine of our bodies is truly fascinating. So I'm
Yeah.
curious, like in your work, especially when you're working with all these different like pathophysiologists, like what's happening when there's an actual disease state. I think this is a good time to get into that because I think this is an area not a lot of people understand what's going on.
Hmm.
Doesn't always get highlighted as much as maybe other disease states. Yeah.
Yeah, I think that's fair to say. And on the note of like astronauts, like
Yeah.
they sort of alluded to, one of the things that is well known that they have to do is they basically have to do a daily amount of energy of exercise
Yeah.
to maintain their cardiovascular and hematologic system because the lack of gravity ends up being actually pretty deleterious to us in ways that I don't think I would have expected. But
Yeah.
without that low grade kind of chronic stress, your body atrophies in ways,
Yeah.
and these parameters go down and that's been now well known, and so
Yeah.
they have basically forced exercise to keep themselves, in that case, just normal.
Right. Imagine if that was the case on our planet.
Yeah.
Like we
Yeah.
had to
If we were all on the
exercise.
moon, what would we be looking like, right?
Right, right. And it's like if it was necessary
Yeah.
to
Yeah.
function, that would be interesting. So,
Yeah. And so, delving into then more of the blood cancers, and I sort of picked this particular one that's my passion, but
yeah,
two, um, hematology and oncology have kind of been intricately linked historically, and so they often get lumped together. So you often hear people talk about themselves being hematologists, oncologists, even though, why is blood tied to cancer as a
yeah,
whole, as opposed to like in one other organ or so? And the answer in some ways is somewhat simple, and it's really historical. Leukemia especially ended up being just a model that was used for cancer and a very successful model in the early 20th century. And so that ended up being then sort of the uniting factor, it being a blood issue and also a cancer that then moved along both of those fields in a very beneficial way. And so for historical reasons, it's always been tied together. And a huge portion of hematology is the hematologic malignancies, the blood cancers. And so, I think let's start there. Let's talk about like leukemia, which is an old disease, and it comes from the root of the word emia at the end. That suffix means situation of the blood. So if you talk about anemia, emia is referring to the situation of the blood. Hyponatremia, low sodium, emia referring to the situation of the blood. And leukemia, leukos, is a prefix that means white. And so the situation of white blood is when there are too many white blood cells that have been spat out by an abnormal bone marrow, by a cancer within the bone marrow. And so it looks, if you ever see a patient with a blood draw who has a massive amount of leukocytes in the blood, it looks pale. It looks not like what you expect at all of the red vitality that comes from the typical, blood draw. It looks very different. And so that name stuck. So we call that still leukemia. And really what it is, and if you take all the blood cancers, leukemia, lymphoma, myeloma, I'll first say that what you call it matters less as we've come to understand, and what matters more is understanding what is the cell that became cancerous. So, in the process of hematopoiesis, going from a stem cell, a pluripotent stem cell in the bone marrow, all the way down to something as specific as a red blood cell or a T lymphocyte or a plasma cell, in that journey of development, wherever the alteration occurs, that's what really defines then the type of cancer. So it really comes from what is that cell type. And then for some more historical reasons, whether we've called it more of a leukemia or lymphoma or myeloma is a little bit artificial there. And I know that's going to get me in a little bit of trouble saying that, but there's a lot of truth to that. Because as we've understood things a little bit more on a molecular level, we see that like, okay, what we call this doesn't matter so much, but understanding what is the cell that became dysfunctional totally matters. So I'll give an example. So one thing that we'll chat about here is chronic lymphocytic leukemia, or CLL, which is synonymous to something else called small lymphocytic lymphoma. It is the same disease. We just have
okay,
two different names depending upon kind of how we wanted to call it. One looking a little bit more one way, one looking a little bit differently. Then we realize, oh, this is all the same thing. So one is a leukemia, the other is a lymphoma, but it's really the same disease. It's an abnormality of a B lymphocyte that acquired a set of mutations and then developed into this cancer that we call CLL or SLL. And leukemia in general is there are four main types, but there's more beyond that. But in general, it's a cancer of some progenitor blood cell somewhere, classically a stem cell. So a stem cell or early blood cancer cell, a blood cell that becomes cancerous, usually forms a leukemia. And there are four main types, as I said, and I think one of the ones that becomes most prominent is acute myeloid leukemia. So backing up a hair, when we talk about hematopoiesis as the process that our body makes blood cells from that stem cell down to the specific mature cell types, you have what's called the myeloid lineage and then the lymphoid lineage. And what I like to say is that if it's not lymphoid, it's myeloid. That's just the easiest way to think
okay,
about it. So kind of early on, a stem cell becomes either a lymphoblast and it then dedicates itself to becoming a set of lymphocytes, either a B cell, T cell, and or eventually a plasma cell from B cells. And then there's NK cells as well that can get thrown in there, but B cells, T cells by and large. And if it ain't that, it's myeloid. So that's where red blood cells, macrophages,
Yeah.
neutrophils, platelets all come from the myeloid lineage. The lympho versus the myelo kind of is tied to then part of the discovery of where that those came from. So myelos refers to marrow or spine. So hence myeloma, myeloid refers to the marrow there. And lympho comes from like the reference to the lymphs from the lymphatic system, the lymphoid tissue, and that's where some of those lymphocytes were found, and that's where the name has been dedicated. So if in the process of hematopoiesis, if a myeloid type of stem cell, which there are many because they're making so many cells, if that becomes cancerous, that's acute myeloid leukemia. And that's a very common form of leukemia in adults. Um, it leads to a few classical things. And one of the most, I think, interesting things about it, and this is true of many other leukemias as well, is that weirdly can actually cause low blood counts. Now, how does that end up being the
Yeah.
case? You would expect high blood counts, and
That's right.
classically it does, right? That's where you get that tube of blood, leukemia, that name. But what can happen is, and this sort of harkens back to our discussion about some disease states and just how can blood really be, how different blood can be in a disease state compared to normal. When the bone marrow gets so chock full of these abnormal cancerous myeloid stem cells, it interrupts some of the mechanisms that the bone marrow can allow those cells to seep into the peripheral blood, to what
Mm.
floats around.
Yeah.
So ironically, it causes all these low blood counts. But then when we go into the bone marrow with what's a bone marrow biopsy to see what's going on with the factory here, you see, oh no, it's chock full of these stem cells, what we call blasts, and that is that is classic for leukemia. Um, Another very interesting form of leukemia, which brings us to something relevant for the modern age, is chronic myeloid leukemia. So this is different from acute myeloid leukemia, despite
Right.
its somewhat similar name. Totally different. And I like to highlight it because it's really just such a success story that we've had in the field. So this is a type of cancer that has really one very key genetic molecular abnormality, and it's a gene called BCR-ABL, where basically two parts of different chromosomes kind of swap in an unfavorable way, and it's named after the city Philadelphia, so it's called the Philadelphia chromosome, and it makes an abnormal protein, and that protein actually defines the illness of CML, chronic myeloid leukemia. And that was known for a little while, but no one could really do anything about it. And these people, unfortunately, their survival was just limited to months to
Yeah.
years as that degenerated and became a more significant problem. Until a drug that was developed then in the 90s that was able to focus on that. And that drug is imatinib. And it really ends up being the first very functional oral chemotherapy. And it targets that specific BCR-ABL issue. And by blocking that, by minimizing that, by not allowing the pathologic protein to be produced and the trouble that it then causes, these people who, again, had survival on the orders of just months to years, live functionally normal lifespans.
Mm.
It turns it into basically a
Wow.
true chronic disease. And as long as people are taking that tyrosine kinase inhibitor, that type of pill that inhibits this, they have done extremely well. And so that is a great success story in hematology here.
That's incredible, by the way. I mean, that's a pretty large change to just essentially have it be a chronic disease that you could live with versus a matter of months. I mean, that's incredible. So, what would be the symptomology of someone who's coming to you? Like, what they're like, I'm not sure what's going on. I'm starting to feel certain things. What would be that? Yeah.
Yeah, and that's one thing that could be so insidious with the blood cancer. So if you take something very different, like a lump on the breast,
Mm-hmm.
that's obvious in some ways. That's something that's palpable, but being within us in the way that it is, many of these hematologic disorders, and particularly the blood cancers, they're pretty silent. And so it's
Interesting.
often just vague symptoms that people describe. They just don't feel well. There's fatigue that's out of proportion to anything that they would expect and something different from what they were experiencing before. And then some things that can come up that do signal us to hey, take a closer look is, recurrent infections, because as those white blood cells get compromised, we start to
Okay.
see that. um, bruising, bleeding, or even actually clotting issues, because as those platelets get compromised, we see that. And the fatigue aspect comes from compromise of the red blood cells. And so that's a clue for, hey, something might be cooking here. And, I'll say, fortunately, one of the most basic tests that you get anywhere around the world whenever you see a clinical provider is a complete blood count. It's just a simple blood test. People get it literally every single day. And gives a wealth of information about what's going on with the
Mm.
blood and is a great clue for what may or may not be happening.
Oh, interesting. Is this a large genetic component to this, or is it due to other factors?
Speaking about like the blood cancers overall
Yeah,
or just some
blood
other
cancers
parameters,
overall. Yeah.
they're so diverse. The answer is yes. For some of them, yes, very much so.
Okay.
And for the others, we actually have no idea and probably
Mm.
not.
Curious. Interesting.
And so it just speaks to how diverse the substance as the blood is that the disorders sort of match that. So there's certain like genetic abnormalities that are inherited that we see a high rate of certain blood cancers. So one example I'll give is something called Li-Fraumeni syndrome, which affects a protein that our bodies make called P53, which is kind of like the guardian of our genome. It's kind of what's been called, sort of protects our genome from a lot of these alterations. And if people have an issue with that from birth, this syndrome, Li-Fraumeni, they can get all sorts of cancers, and amongst them, blood cancers. So that's one where we see a little bit of a link. And then something where we don't seem to see much of a link would be certain types of lymphoma, where we see them seemingly sporadically. We don't really
Hmm.
have a whole lot of rhyme or reason for why people get it, and it could simply be an erroneous event in one of those blood cells that occurs that then just gets propagated forward and unfortunately presents itself.
Wow. I mean, I think the vagueness of it makes it a little scary, I would
Mhm.
say. It's
Yeah.
because like you said, I think when there's like a physical palpation of something or something that's like you can see it aesthetically, like there's a huge change in you. But to not have that, I think that feels a little nebulous in many ways. Like
Unnerving, right? Yeah,
unnerving. Yeah, it's scary. Like honestly,
yeah.
just scary. Yeah.
Yeah, I totally feel you there. The comfort I'll give there is that if you look at the big four in cancer, it really ends up being lung cancer, breast cancer, prostate cancer, and colorectal cancer.
Right.
And interestingly, despite again how cellular the blood is and how many cells it's spitting out, and that's opportunities for significant error and hence cancer, um, it's actually much lower on the list. The
Mm,
blood cancers in general are actually considered to be quote unquote rare by
rare.
comparison.
Okay.
Which again, that's I always have found that myself to be very interesting. Like, why is that the case?
Yeah.
And that's because I think over time the body over evolutionary mechanisms has figured out a way to contain a lot of those abnormalities to where it does a pretty good job, all things being said.
Yeah. Wow, that's interesting. What's usually I know you mentioned about like for adults, like is there kind of a juvenile aspect to this where
Hmm.
children have this or and generally what's the onset or is there an
Yeah.
average age onset to any of these blood
Yeah, and
cancers?
and it depends on sort of the type. So, like if you take something like multiple myeloma, a cancer of the plasma cell, its median age of onset is somewhere around 69 years.
Okay.
And if you take something like acute lymphoblastic leukemia, ALL, it interestingly has kind of two peaks. So one is the pediatric population, so around age of 4, and that's the childhood leukemia that people know and see about. And then there's a much later peak later in life where it occurs around like the 50s and beyond.
Mm.
And it's the same disease, but it has interestingly a very different manifestation. Then it ends up being clinically quite different as well. If you talk about pediatric leukemia, pediatric ALL, it has wonderfully an amazing cure rate nowadays. It approaches 85 to
Oh
90%
wow. Yeah.
for something that was very fatal, less than a century ago to what it has achieved now is really
Wow.
a credit to the field and to my pediatric hematologist, oncologist. My hat goes off to them for what they've been able to do. And then on the adult side with ALL, it's not quite as good. That ends up
Okay.
being much more of a struggle. And why exactly that is actually a really interesting question. And I don't think we really know. I certainly
Mm.
don't. And it's an active area of interest, but we do know that these diseases have other acquired abnormalities that go on. So even though it's categorized under the same broad banner, the molecular cytogenetic features are actually reasonably
Yeah.
different. And so it just ends up being a different disease functionally.
Interesting. I start thinking. is there a difference just because of age? That someone who's super young and doesn't have, for lack of a better word, the mileage and
Yeah,
the
yeah, the
damage
exposures,
that,
right?
right,
Yeah,
the
yeah,
exposures over time
yeah.
versus someone who's in their 60s has had a lifetime of exposure and of just life and
Yeah,
stimuli.
yeah.
I don't, that's just a thought I had about it.
Yeah, there's this saying that in medicine and public health in general that living causes disease. You
Yeah,
get this accumulation of exposures, and that's just what
right.
happens, right? We're not going to be
Yeah.
immortal unless, some billionaire figures that one out.
Yeah, I think
Um,
Dr. Matthew Walker talks about this with sleep, like the damage of wakefulness. Just
mm,
being alive.
yeah,
You're
exactly.
basically
That
taking in
oxidative
asteroids.
stress.
Yeah, I
Yeah.
mean, it is what it is.
Yeah, it absolutely. And I think, so like if we talk about cancer in general, and this is very much true of the blood cancer as well, the number one risk factor really does end up being age. And it might not be age per se that's the issue if you think about it. It's probably the accumulation of these stressors that
Yeah,
occurs with aging that is probably doing the damage. So that's really true across the board. Um, but it's a question that people often ask of, hey, why did I get this? And it's such an important one. And you can talk about things at kind of like a broad level. So with the blood cancers and a lot and very other much other aspects of hematology, when the atomic bombs were dropped in Hiroshima and Nagasaki, the Hiroshima Study Project, what then looked at the survivors and some of the horrific things that they had happen to them. Amongst other things, was this huge spike in leukemias, lymphomas, myelodysplastic
mm,
syndromes, and myeloma. And that then kind of kicked off to understand, like, hey, ionizing radiation is bad here, kind of speaking to what our ultraviolet stress on the bone marrow can do. And as we've learned then over time, other industrial solvents and all these other things are unfavorable. Um, but that's, as you're kind of getting back to it, that's not true of a child then, right? If they don't
that's
have those
right.
exposures. So there's a lot more there that I think we just
Yeah.
we just don't know.
What what contribution does nutrition play into these disease states, blood-based
Yeah.
cancers?
Yeah, and that's one thing that we have there's so much interest in, and it's so hard to study. So nutritional
Mm,
epidemiology, I think, is rife with complexity and sometimes the wrong way. Like you see
yeah,
conflicting results and I think part of it has to do with one, how do you study it properly, right?
that's right.
So much of this is retrospective. You're going back, asking people what their intake is and looking at associations. It's really hard to do proper randomized controlled trial type of designs. And the other is just the time course.
That's right.
You're looking at something that your habits as a teenager, adolescent might have contributions to when you're in your 50s and
Yeah.
beyond. That's a hard study to do.
Yeah.
And, and if you take someone who's 50 now, what they were doing back then versus what back then when they were an adolescent versus an adolescent now, it's
Yeah.
like night and day between all these other exposures too. So it's a hard thing to answer. But that being said, the generality seems to be true that diet 100% has a role to play here,
Mm,
especially as we talk more about um, like microplastics, like our
mhm.
understanding about that, in processed foods, things like xenoestrogens, substances that
Yeah.
have an unfavorable endocrinologic effect against us. Um, we nitrosamines, we know that these have harm in accumulation. Now, the individual contribution might be small, but the lifetime of accumulation of all those is felt to be very much unfavorable. And so it's interesting to me how, I feel like plastic was all the rage for so many decades, and now we try to go back to the way our grandmothers are, right?
Right.
We're trying to remove the plastics from the kitchen. We're trying to go back to whole foods. We're trying to
Yep.
use wood and a wooden spoon, a glass bowl,
Yep.
ceramic, metal, and trying to avoid some of those things that are much more modern and in many
Yeah.
ways more convenient. But then the specific mechanism of how that occurs, that still is unclear. So we know
Yeah.
some aspects of it in the way that it can interfere with some of these cellular pathways, but then what's happening more fundamental to that, I think it remains to be discovered.
And that's, yeah, just, you make a good point about that, about kind of your habits way in the past versus what they are now and your exposures. It almost makes me think that it's very difficult to study anything like this because everyone has similar but different exposures. We're all living very different but similar lives, and whether our exposure to smoking, our exposure to environmental issues, pollution, certainly individual behaviors, it makes it
Hmm.
incredibly difficult to like say, this is it. This
Yeah,
is the reason.
exactly.
Yeah.
Exactly.
Right.
Yeah. In an ideal sense, you'd be able to do some sort of randomized
Yeah.
controlled trial for everything, but that's just not at all
It's
feasible.
no.
And I don't know that it's always necessary either.
Yeah.
Like it's said that there's no randomized controlled trial to prove that parachutes work, but I don't think we need that. I think we're okay. I think we can probably
Yeah.
infer what we need to. That it probably does what it needs to do.
Yeah, I think so. I think so. So, I mean, what have you inferred from your time doing this? Like, what's been on as we get close to the end? What have you enjoyed the most about what you do? Yeah.
What I found so refreshing, and my main focus ends up being multiple myeloma, is the progress that we've been able to make
Mm,
despite not knowing so many things. And I think it's been said in science that the more you know, the more you say you don't know. And
right.
there's a lot of truth to that. There's just so many unanswered questions that can be very fundamental and just so fascinating. But there's a lot of progress that's made throughout the journey there. And in the case of multiple myeloma, and I'll speak to that specifically, similar to CML, um, we've made strides. Survival for multiple myeloma, not too long ago, just a few decades ago, was really measured around the order of maybe like 3-ish years median survival, versus now, it's in excess of what seems to be 10 years. And actually, just at a conference earlier this year in 2026, we're starting talking about actually the possibility of cure, of what we actually have a working definition for cure.
Mm.
Now, that's still hard to obtain, but it speaks to the progress in the field of what we've been able to do with all of these discoveries and new drugs and the way that we treat people, and then to acknowledge the supportive care surrounding it has really improved people with all sorts of hematologic diseases.
Oh, that's amazing. It really is. I mean, I think blood is something I think we just kind of take for granted. It's
Mm,
like we just kind of, I don't know, it's something different about it. But
yeah.
it's one of my favorite things to talk about to my students because it's kind of one of these things too where you don't see it unless something happens.
Mm.
It's like, oh, you cut yourself. You're like, oh, there's the blood,
Yep,
or
yep.
you don't really think about it. And I think that's
Yeah.
what's incredible about a lot of bodily systems. And I like how you said liquid organ. I never heard that before. That was amazing. Is there usually these beneath the surface situations? We don't give them less much thought unless there's a disease state
Yeah.
or we
Yeah.
see something. And so, kind of going underneath the hood, I think it always gives me awe
Mm.
for what has to happen inside of our body for you and me to be having this conversation right now. It's truly mind blowing. It feels like, yeah.
Totally agree. If you take the example of something as simple as just nicking your finger, which is, totally minor, right? That's happened
Yeah.
for God knows how many millions of years. But think about what happens with platelets coming to that site,
Right.
plugging that up, all the coagulation factors activating the cascade with over 13 known substances and many more auxiliary substances to form then this fibrin sheath, this mesh, which then plugs up that bleeding to make it as minor as it is. And then in a disease state of certain platelet disorders or hemophilias where more minor cuts can actually be then life-threatening. And, there's a
Mm.
chasm between it to then speak to how successful our hematologic system is.
Yeah, it feels like nothing, but underneath it, if it's like incredible, this vascular spasm, platelet plug,
Hmm.
coagulation, all this stuff. Again, just as you're living your life, you just don't think about it. It's almost like a superpower that you have. It's like
I like
imagine if
that.
that happened, you were like, nothing can be done.
Yeah,
Like you just
exactly.
can't
Like,
be
oh,
cutting
time to
your,
go.
you can't
Yeah.
have any nicks. Like the fact that
Yeah.
this just kicks in immediately is so mind blowing
Yeah.
to heal you.
Yeah. It reminds me of there was this it was a Dave Chappelle skit where he talks
Yeah.
about cholera, kind of,
Yeah, yeah.
randomly, and he sort of says like, back when you couldn't do anything, as soon as you had that first score, he said, "Oh, time to go.
Yeah,
I'm out.
exactly. I'm
Can't do
out. It's
anything about
over.
this."
Yeah.
Versus now we can treat that, right?
Yeah.
It really is a fascinating discipline. The strides made have made it
Yeah.
all the more interesting, and I'm sure in the next few years and
Yeah.
decades, the game is going to change even further.
Yeah. Well, thank you for contributing, being a part of it, and thank you for giving me some of your time. And like everyone, I know you're very busy and you have a lot going on, and I just thank you for sharing your knowledge with our audience here. So, how can everyone connect more with you? We'll have stuff in the show notes, but anything you want to say for people who want to learn more about your work?
Yeah, well, one, thank you so much for having me. It's been an absolute pleasure to have the conversation. Please follow me on Twitter. My hashtag is, my handle is Oncology. My last name KHANCOLOGY. I also contribute to one of our UT Southwestern, my institution's websites, focusing on the blood cancers that I had mentioned earlier. And I give a lot of patient advocacy talks with such groups as Health Tree, the Multiple Myeloma Research Foundation, and others. And so you can catch more of me there. It's some of my talks are on YouTube and beyond. And feel free to drop me a message, DM me. I'm always happy to connect.
That's so awesome. And I have to tell you, everyone in the audience, Dr. Khan he's one of the nicer people you'll ever meet. Seriously, just very easy to talk to. That was the first thing I noticed when we talked on the phone. I was like, this guy's an awesome guy. Just great vibes, energy, and I appreciate that more than you know, man. I just love wonderful
Thank you,
people.
Darian.
You seem like a wonderful person. Thank you for being a part of this experience. Yeah.
Thank you so much.